Good morning, dear students. So today also we are going to talk about the different clinical cases and clinical scenarios. So we are going to talk about that and solve right here in the class. Okay, let's proceed further. So today I have mainly compiled the cases from hematology. See here, this is the first case. A 4-year-old boy, the age is just 4 years old and is the male child, presents with pallor, petechiae, and a painful limp. So this is the chief complaint: pallor, petechiae, and painful limp. He has lymphadenopathy, and chest X-ray shows a widened mediastinum, reported as a possible mass. So probably this widened mediastinum is caused by lymphadenopathy in the mediastinum. Okay, because of the related description here. The most likely diagnosis is which of the follows? Is it Hodgkin's disease? Is it acute lymphoblastic leukemia or ALL? Is it AML? Is it mediastinal B-cell lymphoma, or is it tuberculosis? Now, let me clarify this, and you can choose your answer on your own. Age is 4 years. Leukemia, especially ALL, is very common between 2 to 6-year-old child. Okay, it is more common in male child. That child usually presents with pallor, okay, petechiae, and bony infiltration or joint involvement. As a result of that, okay, the walking is, or uh, putting weight on the limb is very painful. That is the meaning of painful limb. It is because of bony infiltration or joint involvement. The same child is having lymphadenopathy and mediastinal involvement as well. So all the things are pointing towards acute lymphoblastic leukemia, ALL. Now you may argue, why not Hodgkin's disease and why not AML? Isn't it in very late stages? Even AML and Hodgkin's disease can have that, but age is not a factor here. That is not common in such a young age. Number one, and ALL is much more common than all of them. Much more common than all of them. Now, one small question for you. If I do total WBC count in this child, what will be the result? Total WBC count. Anyone?
W, WBC may be increased in ALL or may be normal, but
Good. Okay. He said WBC count may be increased or normal or decrease. Anything. Okay. Decrease, normal, or increase. Actually, decreased WBC count is the most common presentation regarding, total count and differential count in case of leukemia. Decrease count, but some of the child may present with increased WBC count as well, or some other may present with even normal count in the beginning. And what is the most diagnostic investigation? What is the sure shot investigation you like to do here? Yes, which one
bone,
is
ma-
that?
what- bone marrow biopsy.
Exactly. Exactly. All of you know that. Okay. Bone marrow aspiration or biopsy is the gold standard investigation here, which will give the diagnosis. If you are lucky enough, even the peripheral smear analysis can show blast cells, but do not rely on that. You have to go for bone marrow aspiration to confirm whether it is ALL or not. Now, according to bone marrow aspiration and biopsy, how many blast cells should be present there to make a diagnosis of ALL? Yes. How much? How many percentage?
More than 20%.
More than 30 or 20%.
More than 30, okay? More than 30. Remember that. It is more than 30% to say it acute ALL, acute lymphoblastic leukemia. We need more than 30% blast cells. So these are some of the important discussion. Let's move on. So see there, the answer is ALL. ALL is the most likely cancer at this age, 2 to 6 years. Children often present with leg or bone pain and limp with non-specific lethargy, poor feeding, and irritability. This is because of anemia. Causes of a mediastinal mass include lymphoma, tuberculosis, retroexternal goiter. Okay, retroexternal goiter. See this? These are the differential diagnosis of mediastinal mass. Lung or other malignancy, including teratoma in a child and thymoma. So if somebody asks you what are the differential diagnosis of mediastinal mass, you can take this name. Lymphoma, common in children. Tuberculosis, also common. Retroexternal goiter is rare in children. Okay, lung malignancy is very rare, except teratoma, which is a germ cell tumor, and thymoma. It can be seen. Thymomas and goiter tend to occur in the anterior mediastinum, though, and other general causes of mediastinal widening include aortic dissection and aneurysm, which are unlikely in a child. So this case teaches us not only about ALL, but about the differential diagnosis of mediastinal mass as well. And one small point I like to move before I go further: T cell ALL. Okay, T cell ALL is the one which usually causes mediastinal mass. It's not B cell ALL, it's T cell ALL. Let's go to the other case now. Number 2. So all of you please focus. Okay, please take a paper and pen in front of you, write the important points, and then always try to solve it. Okay, this is the way to learn. A 43-year-old female present with epistaxis, means bleeding from the nose, bruising, and menorrhagia for 1 week. What is menorrhagia?
Heavy menstrual bleeding.
Exactly. Heavy menstrual flow or bleeding. She is febrile and appears unwell. So see there, she is febrile and appears unwell. So there is fever also, and she appears sick. She is diagnosed with acute promyelocytic leukemia. Already the diagnosis has been done. So this is according to FAB classification. Which is this? Which classification is this? Acute promyelocytic leukemia. Yes.
M3.
Very good. Excellent. It's M3. Excellent. M3 according to FAB classification. French, American, British classification is used for AML, and this is M3. Which of the following are the most important aspect of our initial management? So multiple choices are there. Okay. So think about it. When we manage AML, there are certain general management and there are certain specific management. So probably there are multiple choices here. Broad spectrum antibiotics, platelet transfusion to keep platelet more than 50,000. This is more than 50,000. Cryoprecipitate to keep fibrinogen more than 1 gram per deciliter. All trans retinoic acid, and blood transfusion to keep the hemoglobin more than 8 gram per deciliter. So who can answer this? Anybody?
Yes, sir. Broad spectrum antibiotic, because it is associated with DIC. So if we give platelets, it will be consume platelets in DIC. So we will give broad spectrum antibiotic, then we will give platelets if they need.
Okay, good. Anybody else? Very good, Khatir. Anybody? Is that the only thing we give here?
Sir,
So
we
all
can go
trans
for
represent-
multiple
Yeah.
options
Good. Like?
because sir, she is already having thrombocytopenia
Mhm.
and febrile, maybe having severe infection
Mhm.
and also leukemia. So we can we can also give the platelets,
Mhm.
and we can also give the cryoprecipitate
Mhm.
fibrinogen.
Mhm.
I mean to say, sir, more than 1 or 2 options, sir.
Okay, good. So there are multiple options. Good. So I like to hear one more answer. Very good, Yunus. Excellent. Anybody else?
Sir, this is a case of M3, so specific treatment for M3 is D. And for symptomatic treatment, we can give antibiotic. We can also give platelet and cryoprecipitate. because the patient is febrile and also bleeding.
Okay. Now here, most of the students, the whoever are answering here have very good concept already, but so many students have joined this, teaching. So for the sake of all of them, I'm explaining it. Please listen properly here. This is a case of acute promyelocytic leukemia, an important type of AML, M3 type of AML. And in this condition, DIC is very common, disseminated intravascular coagulation. That is highly specific of AML. On top of that, okay, the WBC count is usually low WBC count, relatively immunocompromised condition because of pancytopenia. And the evidence of pancytopenia are already there from the clinical picture. Look here, there is epistaxis and bruising. Okay, as a result of DIC also, there is decreased platelet. And as a result of malignancy itself also, there is decreased platelet. So I can explain this epistaxis, bruising, and menorrhagia because of DIC or because of thrombocytopenia. Okay. Another clue: she is febrile and appears unwell. Means there is a part of infection also there. So WBC count may also be low. That's why infection is common there. So I need to give broad spectrum antibiotic to cover this infection. There's a definite choice. Platelet transfusion is also given in case of DIC. Remember, in DIC, the platelets and clotting factors are used up. They are utilized. So they are decreased in count and level. So I have to give platelet. Make sure platelet count is more than 50,000 so that there is no more bleeding. Cryoprecipitate is given to keep fibrinogen above 1 gram because this is a case of DIC. So cryoprecipitate is given in the treatment of DIC. Okay, fresh frozen plasma and cryoprecipitate. These are the important medicines there. All trans retinoic acid is the specific treatment of acute promyelocytic leukemia. This is vitamin A derivative and it is used there. And the last one, usually these patients are anemic also. Look at the causes of bleeding here, menorrhagia. Okay, this itself can lead to anemia, and bone marrow suppression can also lead to anemia. So blood transfusion is also done to keep hemoglobin level more than 8. So all of the options are correct here, all of the options. So sometimes, examiner gives this type of question just to make sure whether the students can give appropriate reasons or not. See here, A, B, C, D, all are correct. Managing the coagulopathy, that is DIC and hyperfibrinolysis, is essential as early mortality results from bleeding primarily in case of acute promyelocytic leukemia. And all transretinoic acid or ATRA has been shown to cause differentiation of those blast cells, which leads to elimination of them. So this is a specific drug. Let's move on. So please focus on the another problem here, number 3. 18-year-old woman has menorrhagia and iron deficiency anemia. Now again, menorrhagia, and because of excessive bleeding, probably she has developed iron deficiency anemia. She also has a long history of easy bruising and epistaxis since childhood, requiring cauterization. So there is a history of bleeding disorder right from the childhood. She bled excessively after tonsillectomy at the age of 13. So tonsillectomy was done, removal of tonsil. There must be certain indication to do that. And the surgeon found that she was bleeding excessively at that time. Her mother also bruises easily. So there is a family history as well. Okay, mother also bruises easily. Now, remember, if mother and father are also having the similar type of diseases, father history is not given here, only mother. So which type of hereditary problem exists in the family? What do you think? Which is more common to exist here now? If mother is having the same problem. Anyone?
Autosomal dominant.
Dominant.
Excellent. It is dominant disorder. Very good. Autosomal dominant disorder. Recessive disorder, both parents have to be the carrier, and autosomal dominant disorders are much more common than the recessive one. So most probably this is a dominant disorder. So see that this type of information you can get from the case itself. A coagulation screen shows a normal PT and APTT. This is very, very important clue. Normal prothrombin time and activated partial thromboplastin time, and her platelet count is also normal. What is the most likely diagnosis? So we have to rule out one after other, or when we see the correct option, probably it clicks in your mind in this case. Is it hemophilia? Is it von Willebrand's disease? Is it connective tissue disorder? Is it inherited platelet function defect like Bernard-Schullier syndrome or Glanzmann promesthenia, or there is no significant bleeding disorder? So who can, take this case?
Von Willebrand disease.
Yes.
Option D.
Okay. So, okay. Well, wait. Let me listen one after other. Yes. Why von Willebrand disease?
Because platelet is normal and also APT and APTT normal. Maybe there is the factor deficiency which cause the adhesion of platelets. So maybe there is defect in that factor which is released by endothelial cell of blood vessel.
Okay. Now, fine. So I'll come to you. Okay. Yes. Another student.
Sir, in von Willebrand disease, APTT is elevated because that von Willebrand factor act as a carrier for factor 8. So in this case, PT and APTT are normal and platelet count are normal. So the qualitative platelet disorder, platelet count are normal. That problem is function of platelet. So that's most probable answer.
Okay. Now he has given his reasons here. Anybody else? Anybody wants to participate here?
Sir, I think it's both B and D.
Good. Why?
Sir,
Why?
it's
Uh-huh.
sir, it's not hemophilia, sir, because in hemophilia the APTT is not normal, sir. And about the von Willebrand disease, sir, as he said there about APTT, but in von Willebrand disease, like APTT is slightly elevated, but maybe it is normal sometimes, sir. And another reason which I want to give, sir, that she also having family history, which is highly correlated with that, sir.
Good, good, good. Now, see there, the answers you are giving is so nice, I cannot pinpoint any faulty reason there. This is the way we solve cases in medicine. You may be wrong. The options may be wrong. I don't care. Your teacher doesn't care about that, but the reason should be correct. That is the important point here. Sometimes the answer may be wrongly given in the options also. Okay. Now see here. She is a 18-year-old female presented with menorrhagia and iron deficiency. So clear-cut case of bleeding disorder. This is a bleeding disorder case. She also has a long history of easy bruising and epistaxis in childhood requiring cauterization, prolonged history. Okay. So she has a family history also. So we found out that most probably it's autosomal dominant disorder. And the important clue is normal prothrombin time in APTT, but platelet counts are normal. So this may not be the quantitative platelet disorder like ITP or other type of condition where there is decreased platelet. That is ruled out, number one. Okay, but still the qualitative platelet disorder cannot be ruled out. Having said that, okay, that disorder is not very common in the clinical practice. And one more thing here, this normal PT and APTT Now see this von Willebrand disease is autosomal dominant disorder usually. So it matches with the description here. Classical clinical features are common in von Willebrand disease like this. So it also matches. Only point which doesn't match here is normal APTT. I absolutely agree with Aman's description. But having said that, there are three types of von Willebrand disease. Okay, mild, when the von Willebrand level is slightly low, that is mild. Sometimes it is completely absent, that is a severe one. So it may still be the mild type of von Willebrand disease because she is having a long history. Maybe when there is a some trauma like surgery, okay, or during the menses, then only there is excessive bleeding. So still I want to go for von Willebrand disease, in this case probably the milder one. Let's see what is the answer here. Okay, and they have explained here also. So this is an interesting case. Let me go through it. So von Willebrand disease is the option. There is a possible familial tendency to bleed and bruise easily. The nature of bleeding is mucosal, making a platelet problem, and von Willebrand disease more likely than a factor defector hemophilia. Absolutely. Now, one small question: what is the function of von Willebrand disease regarding the formation of platelet plug? What is the real function here? Yes.
Platelet adhesion.
It acts like a breeze between platelet and endothelial factors, or endothelial matrix, I should say, or collagen. It acts like a breeze between them. So without that sticking substance or a breeze, platelet cannot attach to the endothelium. So this is important function. Von Willebrand disease has another function also. It acts as a carrier of factor 8. That's why APTT should be prolonged, but in a milder type of involvement, APTT may still be normal. But in a serious type of involvement, APTT will definitely be prolonged. Okay, so these are the explanation. Let's move on. Number 4. Most of the cases are from hematology today. See here. A 65-year-old female is noted to have the following full blood count: hemoglobin 14. This is the normal range. Okay, so it is within the normal limit. Platelet count 800. Okay, so this is what is the normal platelet count? See there, 150 to 450. Okay, so 150,000 to 450,000. In this case, it is 800,000, or you can call it 8 lakh. This is extremely high platelet. WBC count is also high. The normal range is 4 to 9. Okay, in this reference, it is given 4 to 9 or 4,000 to 9,000, but it depends on different lab. Sometimes it is written 4,000 to 11,000 also. We don't mind that, but see there, it is very high here, 20,000. Differential counts: neutrophil 50%, eosinophils 30%, basophil 5%, lymphocyte 10%, and monocyte 5%. So all types of cells are there, all type of cells in increasing amount. She has 3 centimeter splenomegaly as well, and she has been having transient clouding of a vision in her right eye. Okay, transient clouding of vision in her right eye. What medical term you want to give for this type of complaint? Yes, what is this? What type of mechanism is this? This is a type of TIA, transient ischemic attack. Okay, transient ischemic attack, not exactly that, but somewhere that type of pathogenesis is going on there. Which one of the following best explains the above clinical picture and differential count? Is it eczema? Is it myeloproliferative disorder? Is it lymphoma? Is it tuberculosis, or is it vasculitis? Anybody?
B.
B. Okay, he's going for B. It's myeloproliferative disorder. So which type of myeloproliferative disorder is this?
CML.
CML. Why CML? Why?
Sir, because age is important here, and also patient is having thrombocytosis and leukocytosis. And all types of WBC are elevated, but most of them are from myeloid series.
Mm-hmm.
And also patients having splenomegaly,
Mm-hmm.
and that clouding of vision is because of hyperviscosity, because blood is populated.
Mm-hmm. Excellent. The reason which he has given and the option which he has chosen is absolutely correct. Very good. There's a good concept here. So please listen properly. This type of cases are so commonly asked these days in your exam. This is a clear-cut case of myeloproliferative disorder, most probably CML, chronic myeloid leukemia. Now, the clues for this, one is age, definitely. Another is very high platelet count. In CML, there is thrombocytosis. Look at this, 800,000 or 8 lakh, absolutely high platelet. WBC count is also high, which is a normal feature there. And the important one is a differential count. Look at the presence of different types of myeloid series cell, neutrophil, eosinophil, basophil, monocyte, all are increased. And most of them are mature type of cells. She has splenomegaly also. In CML, splenomegaly is a massive one. Okay, massive splenomegaly. But 3 centimeter is not a massive. Probably they have detected it quite early there. Okay, later on, the spleen may become massive. And then because of all these increased number of cell, there will be hyperviscosity. So hyperviscosity will definitely cause decreased blood flow towards the brain, the smaller capillaries, and then there may be decreased functioning like clouding of the vision in the right eye. You can explain everything from it. So this is a case of CML or chronic myeloid leukemia. Now, apart from CML, there are other examples of myeloproliferative disorder also. Can you name them? What are those? Number one is CML. Okay. What is number two?
Polycythemia.
Good. Number two is polycythemia. Yes. Polycythemia. So let me. Polycythemia vera, isn't it?
Yes, sir.
Polycythemia vera or polycythemia rubra vera, we call it. This is predominantly the disorder of RBC series. Number three.
Myelofibrosis.
Myelofibrosis. Excellent. Myelofibrosis is the number three. This is also known as myelofibrosis with myeloid metaplasia. And number four, yes, number four,
Essential thrombocythemia.
Exactly, essential thrombocythemia. Okay, thrombocythemia. Let me write that for you. Essential thrombocythemia. Okay, this is the one. Good. Now these are very, very typical questions in the exam for most of the students. All of these are myeloproliferative disorder, but this case is typically CML. So see there, the differential shows a high WBC with an increase in myeloid lineage element, neutrophil, eosinophil, and basophil. There is also a significant thrombocytosis. This is very, very important clue. Although this picture could be reactive to infection or inflammation, splenomegaly would be unusual. The history also is concerning for amaurosis fugax. See there, a type of TIA, which may be related to the high platelet count. And this is associated with increased stroke risk because of hyperviscosity, hypercoagulability. Okay. Confirmation of this is done by bone marrow aspiration or biopsy, and patients should get aspirin here because of the high risk of stroke. All other things are quite easy for you. Let's move on. Number 5. Okay, these are a short type of cases today, but you should think about, because these are the hematological cases and you should have a good knowledge, then only you can solve them. But never mind, let's try for it. A 32-year-old man is brought in collapse to accident and emergency with multiple bruises, smelling of alcohol, and extremely unkempt. So he's very untidy, the way he was dressing is probably not appropriate. He's pancytopenic, and there is a raised INR and deranged liver function test. This is international normalized ratio. And whenever INR is raised, the prothrombin time is high. MCV is 125 femtoliter. Okay, 125 femtoliter. If it is more than 100 femtoliter, it is high. That shows there are macrocyte present. So it is a case of macrocytic anemia. There are hypersegmented neutrophils on the phlegm as well, and serum B12 is normal. So what is the most likely diagnosis here from the list? Is it hypothyroidism? Is it autoimmune hemolytic anemia? Is it alcohol? Is it B12 deficiency? Or is it folic acid deficiency? Anyone?
Sir, it is, sir, folic acid deficiency.
Yes, Eunice, can you give some reason here?
Sir, I have clear two clues here, sir. One is the most important is hypersegmented neutrophil, sir.
Good, very good.
And they already excluded vitamin B12 deficiency because
Very-
it's normal in serum.
Very nice.
And the MCV also here is more than 100, so it's a macrocytic.
Excellent reason he has given. Absolutely. Okay, I completely agree with that explanation. This is most probably a folate deficiency anemia. Now, I need to explain one more thing here. This is a chronic alcoholic patient. Chronic alcoholic patient. So, what is the reason? Yes, what is the reason for folate deficiency in case of chronic alcoholic person? What is the reason? Yes, anybody?
Dietary.
Dietary, maybe anorexic.
Exactly. This is a dietary thing. Absolutely. They ignore their diet. This is known as tea and toast diet in case of alcoholic people. They don't take balanced diet at all. They don't care about vitamins. They don't care about minerals. They don't want to, take a bit of nutrients. That's it. And alcohol is the major source of nutrients for them. And yes, alcohol has got calorie, but it is only calorie, nothing like vitamins and other type of things. So over a period of time, they are deficient in multiple vitamins like folic acid, like thiamine, like other types of vitamin. Okay, so that type of explanation we can give here. Now, see, all these other explanations are quite easy. Probably this person is having chronic liver disease already. Chronic liver disease, probably cirrhosis of the liver, and all other explanation can be given accordingly. Now, let's talk a little bit about other choices also. Hypothyroidism is also a very known cause of macrocytic anemia, but cases they don't support, these clues, they don't support hypothyroid case here. But macrocytic anemia is also caused by hypothyroidism. This doesn't look like autoimmune hemolytic anemia at all. Okay, alcohol, yes, can be there, but how can we explain everything under that? Isn't it so difficult? Not a specific type of question. Okay. See that alcoholics and the homeless tend to be malnourished, and folate deficiency is common due to poor intake of greens and vegetable, which are rich in folic acid. So we already talked about that. Note that alcohol and liver disease themselves can cause a macrocytosis and low count, but rarely cause an MCV as markedly raised as this. And B12 deficiency is already ruled out because the level is normal. Now, before the break, probably we can handle one more case. So please have a look here. A 62-year-old male presents with angina, chest pain. He is anemic and jaundiced with hemoglobin just 6.2, MCV 106 femtoliter, reticulocyte 5%. A blood film shows polychromasia, spherocyte, and nucleated red cells. So see this angina, okay, this is a chest pain. The person is anemic and hemoglobin proved that he is severely anemic actually. He is also jaundiced. Reticulocyte is 5%. MCV is slightly higher. And blood film shows polychromasia, means multiple color of the RBC. Spherocyte, okay, spherical shape RBC, and nucleated red cell. That means the bone marrow is working more than the usual. So which choice is the correct one? Is it hypothyroidism? Is it autoimmune hemolytic anemia? Is it alcohol? Is it B12 deficiency or folate deficiency? Anyone?
B12 deficiency.
Why?
Autoimmune hemolytic.
Okay, wait. Let me hear the B12 deficiency reason first. Yes, why you chose that? Okay, why B? Why autoimmune hemolytic anemia?
Sir, anemia and jaundice with reticulocytosis, and also spherocytes and polychromasia. These are features of hemolytic anemia.
Excellent. Excellent. And only one cause of hemolytic anemia is given there, that is autoimmune hemolytic anemia. If probably other causes of hemolytic anemia were given, you can be a little bit confused, only a little bit, but still there are lots of clues here. So please follow, is absolutely right here. Angina. This angina is explained by anemia. Look at the severe anemia here. Anemia can lead to angina. We have studied that because of decreased oxygen carrying capacity of the blood. Okay, this is important point. Jaundice, anemia, and splenomegaly. Okay, jaundice, anemia, splenomegaly, and excessive reticulocyte count. This is the combination of hemolytic anemia. Though splenomegaly is not given here, but we have anemia, jaundice, and reticulocytosis. So this is a case of hemolytic anemia. Severe, anemia is there, 6.2 gram. Polychromasia is another clue given to you, hemolytic anemia. Spherocyte. This spherocyte gives clues towards the autoimmune hemolytic anemia. There are two causes of spherocytosis. One is hereditary spherocytosis, which is a classical one. The name itself is spherocytosis, so nobody can get confused. Another one is autoimmune hemolytic anemia. And nucleated red cell means that the bone marrow is working very fast. Okay, only one reason which you cannot fit is MCV. But remember, if bone marrow is working fast, the immature cells comes out easily in the peripheral circulation, and they are mainly macrocyte. Reasons. The explanation. The features here are of typical of hemolysis, and only one condition that gives hemolysis was given that is autoimmune hemolytic anemia. In autoimmune hemolytic anemia, the direct Coombs test is positive, but that option was not provided there. Okay, spherocytes are the product of red cell that have bits of membrane removed by the spleen as a result of antibody coating. Yes, the abnormal antibodies are responsible for autoimmune hemolytic anemia in this case, and those antibodies are produced by the immune system. The younger red cells, which are reticulocytes, are increased in hemolytic anemia and tend to be larger in size, hence making the MCV a bit of high. So don't get confused. Not all high MCV are either B12 deficiency or folic acid deficiency. Okay, in that condition, probably they are a bit higher, like 120, 125 femtoliter, 115 means much higher than 100. A little bit towards 100 may be present in hemolytic state as well. And then polychromasia is a hallmark of hemolytic anemia. So all of these are, matches there. Let's move on. Another case, please focus here. A 40-year-old female presents with weight gain, hair loss, and lethargy. She is a female and she presents with weight gain, hair loss, and lethargy. deep tendon reflexes are reduced. Her MCV is again higher than the normal, 102 femtoliter, and she has a mild anemia. So what may be the cause for that? Is it hypothyroidism? See, the options are same, but the way they are giving, or asking questions is different. Is it autoimmune hemolytic anemia? Is it alcohol? Is it B12 deficiency, or is it folic acid deficiency? Who can answer this?
Hypothyroidism.
Why?
Because there is weight gain, hair loss, and lethargy, and deep tendon reflex also reduced. And MCVs may be related to autoimmune disease because hypothyroidism is the common cause of hypothyroidism in the female. So it
Mhm.
may be leads to pernicious anemia and then between megaloblastic anemia. This.
Good, very good explanation you have given. Excellent. Okay. Anybody else? Very good, Khatir. You're absolutely right. But still, I want to hear one more answer. Anybody? Any other students? Is it the same explanation? Okay. Now, this is absolutely correct. So nothing more to talk. Actually, she is a female, 40-year-old. In female, hypothyroidism is quite common. It has a classical symptoms like weight gain, hair loss, or alopecia, and lethargy. When we do the central nervous system examination, the deep tendon reflexes are decreased or reduced. And one more important thing here is the relaxation phase of the deep tendon reflexes are prolonged. Okay, this is known as delayed relaxation. Our MCV is 102 femtoliter. So macrocytosis is also present here. And this is seen in hypothyroidism. I already talked about that. It may be the direct effect of the decreased thyroxine hormone on the maturation of RBC, or he's right, you know uh, most commonly hypothyroidism is caused by Hashimoto's thyroiditis, one of the common cause. That's the autoimmune phenomena. And who knows, autoimmune hemolytic anemia may coexist along with that. And just now in the prior cases we have seen, in autoimmune hemolytic anemia there may be slight chance of macrocytosis. Okay, so probably the first cause is more likely than the second one here, but still I can safely give this reason. So hypothyroidism is the correct answer here. Let's move on. So these are the features of severe hypothyroidism. Okay, now number 8, a 50-year-old male patient with lethargy, splenomegaly, and the following blood count: WBC, okay, 60, neutrophil 55%, myelocyte 25%, and lymphocyte 2%, eosinophil 5%, basophil 1%, monocyte 1%, and even blast cells 1%. This 60, remember, whenever they write like this 60, it is always 60,000. Okay, WBC count is denoted in thousand, so 60,000. So it is high, and the differential count shows all different types of cells are present. Platelet 600 means 600,000, again very high. Hemoglobin 11.5, slightly low. BCR ABL translocation, or another term is Philadelphia chromosome, is detected by fluorescent in situ hybridization analysis on peripheral blood. This is a type of DNA analysis. Now, I'm sure all the students who are who have attended our previous lecture or studied any topic of hematology can solve this question. What is the correct answer? Who want to pick the correct answer here? Anyone? Yes.
CML.
CML. Why CML? Give me only one reason. Why CML? Just a reason, one reason.
Sir, because of Philadelphia chromosome.
Because of Philadelphia chromosome. Another student, can you add one more reason apart from Philadelphia chromosome here? Anybody else? Anyone? There are so many reasons. One is splenomegaly. Okay, all these lethargy, very high WBC count, very high platelet count, all different types of cells present, especially the myeloid series. We have just discussed this case before. And this typical Philadelphia chromosome all are points towards chronic myeloid leukemia or CML. Straightforward case. Okay, so this patient has CML with a marked leukocytosis, 80,000 year, with a myelocyte and neutrophil peak. There is also an eosinophilia, excessive basophil, and platelet count. Occasional blast cells are also there because CML has got three important phases. The first phase is called the chronic phase or phase of stabilization, we say. Second phase, okay, is called accelerated phase, and third phase is called blast crisis phase. So CML can go towards AML. So I can say that this is probably a bit of going towards the acceleration. Till now, the situation is not that severe, but it may go very soon to the blast crisis phase. And one of the important hallmark of CML is Philadelphia chromosome, that is BCR-ABL detection by fluorescent in situ hybridization that confirms the diagnosis. But please remember one thing, Philadelphia chromosome is not pathognomonic of CML only. It may be present in other types of leukemia as well. And Philadelphia chromosome, if present in other leukemia, the prognosis will be poor. In CML, okay, presence of this gives rise to good prognosis. Let's move on. Number 9. A 40-year-old male, okay, presents with lethargy and 16 centimeter splenomegaly. It's a huge spleen, 16 centimeter. He has a leukoerythroblastic blood film. Leukoerythroblastic blood film, lots of leukocytes and erythroblasts or RBC. Bone marrow, we tried bone marrow, but it was a dry tap, unable to aspirate the bone marrow. The bone marrow is already dry or fibrotic. There is marked increase in reticulin on trephine biopsy. So bone marrow is replaced by this, a lot of reticulin is seen, reticular fibers are seen. So what is the correct option? This is a straightforward case. What is the answer here? Anybody?
Sir, I don't know, but maybe myelofibrosis because there may be a dry type of bone marrow which cannot be spread.
Okay. Any other? Very good. Good answer. Yes. Anybody else?
Sir, it's option D, sir.
Option D, myelofibrosis.
Yes, sir.
One answer he has given, it's dry tap. Any other you want to give? Any other clues you want to provide to me here?
Yes, sir. Sir, it's about 16 centimeter enlargement of spleen. That is massive enlargement. And the second one is leukoerythroblastosis, which is mean that the extramedullary hematophasis is going on.
Good.
And blood cells are synthesized by spleen and liver.
Good.
Instead of bone marrow because
Good.
it is fibrous.
Excellent. Okay. Very good reason he has provided. All of the points are absolutely correct. Now see this. Let me explain this for you. This is the most important clue here. Massive spleen, 16 centimeter huge spleen. Probably this spleen has crossed the umbilicus and may have reached, even below that towards the right iliac fossa. Leukoerythroblastic blood film. This is typical of myelofibrosis. If you follow the hematology textbook, it is written here because in myelofibrosis the bone marrow fails. So there is extramedullary hematopoiesis that mainly occurs in spleen and liver. And the bone marrow aspiration proved that it is a dry tap, means there is not much bone marrow tissue inside. So all of these points are pointing towards myelofibrosis, also known as myeloid metaplasia here. Now, let me take this opportunity to talk about massive splenomegaly here. Okay, this is a case of massive splenomegaly, and the definition of massive splenomegaly: when spleen crosses umbilicus during the examination. Spleen crosses umbilicus. Now, what are the causes? That is a typical question in the exam. The causes of massive splenomegaly. Okay. The number one cause is written here, myelofibrosis. Okay. What is another one? Anybody? What is another cause?
Leishmania.
Leishmaniasis. We can call it chronic leishmaniasis or chronic Kala Azar. Chronic leishmaniasis or chronic Kala Azar. Chronic malaria is another one. Okay, Kala Azar. I am going to write it here. Wait. See, Kala Azar. Okay. Then Kala Azar or leishmaniasis is right. Malaria. Okay, malaria is the third one. This is again chronic malaria. One entity of chronic malaria is called tropical, okay, syndrome. Okay, malaria.
ITP.
Number four is lipid storage disorder. Lipid storage disorder. What are the
Goucher
example of lipid storage disorder? Yes.
Goucher and
Goucher.
Niemann-Pick disease.
Very good. Very good. Gaucher disease and Niemann-Pick diseases. Gaucher and Niemann-Pick disease. And number 5 is associated with cirrhosis of the liver. What is that condition?
Portal hypertension.
Portal hypertension.
Portal hypertension.
Exactly. Portal hypertension. Now, some other causes may be there in the textbook, but these are the very typical one which causes massive splenomegaly, like typhoid fever, tuberculosis, infectious mononucleosis, and all of those causes not that big spleen. So these are the favorite questions in the examination. And don't forget CML, okay? Let me write CML also here, massive splenomegaly. Now, you already got the explanation for this. So these features suggest marrowfibrosis or myelofibrosis. Now let's talk about another case, that is case number 10. Now see here, this is a 3-year-old boy with bruising and irritability. Bruising. So this is a bleeding disorder or bleeding tendency, and irritability maybe because of pain somewhere in the body or maybe because of anemia. These are the common causes of irritability at this age. He has a white cell count of 100,000, okay? Hemoglobin 5.7 gram and platelet, okay, 20. It's just 20,000. This is a per cubic millimeter, okay? Just, correct it, 20,000. And he has presence of hepatosplenomegaly as well. A blood film shows a monomorphic population of small blast with no granulation and scanty cytoplasm. Myeloid surface markers are not detected. So which option you want to choose here? Yes. What is the correct answer here? Just take a bit of time and say, okay, fine. ALL, why? Give me reason, please.
Sir, because age is very important here, just 3 years, and also leukocytosis and anemia and platelet count is low with hepatosplenomegaly, and blast cell are seen, but and there is a absent myeloid surface marker, and nuclear to cytoplasmic ratio is high.
Good. So all of those, yes, please.
So in AML, the nuclear cytoplasmic ratio is low. So this is ALL, which is common in this age.
Very good. So most of the reason, whatever he has given, all correct. See there, it's a straightforward case of leukemia. Every student can pick that because there's a presence of blast cells there. Okay, whenever blast cells are given, it cannot be aplastic anemia. It cannot be ITP. So these two are easily ruled out. Now only doubt is whether it is ALL or AML. Now see this, myeloid surface markers are not detected. This is one clue which is against AML, and another one, look at the morphological appearance of these blast cells. There are no granules. In myeloblasts, there are lots of granules present. They are granulated cell. And number two, scanty cytoplasm is there. Okay, scanty cytoplasm means nucleus is big in size, and there is very less cytoplasm present. This is seen in lymphoblastic cell. In myeloblastic cell, the nucleus is slightly smaller than lymphoblast. Having said that, the area which is present in the cytoplasm is more. So these are the different clues for us. And this is a example of ALL where the WBC count is high. Have a note this. So not all the time the WBC count is low or normal. Sometimes it may be high also, and platelet count is low there. Sorry, this is 20,000. Okay, hepatosplenomegaly is a feature, is a non-feature of ALL, and age is very typical. Sex is also typical. So this is a clear-cut case of ALL. So see there, the same diagnosis can be asked from a different angle. That's why concept is really important here. So this child has ALL with marrow failure as a result of infiltration with lymphoblast. ALL is the commonest tumor in this age group. The presentation is typical. Immunophenotyping is needed to confirm that this is not AML, although the morphology is highly suspicious of ALL. All rods do not occur in ALL. Okay. All rods, this is a pathognomonic feature of AML or myeloblast only. Now, let's talk about another case from hematology again. A 45-year-old man presents with back pain, night sweat, weight loss, and a 10 centimeter retroperitoneal mass. So there is a huge mass which is present inside the abdomen in the retroperitoneal area. He has a markedly raised LDH, okay, lactate dehydrogenase, and his HIV results returns as positive. So this is a HIV positive case. Histology demonstrates a starry sky pattern, and most of the cells are in mitosis. There is increased mitosis in the cell. So which one of the following is the correct option for you? Is it multiple myeloma? Is it acute promyelocytic leukemia, which is M3 type of AML? Is it Burkitt lymphoma, a type of non-Hodgkin's lymphoma? Is it follicular lymphoma, or is it chronic lymphocytic leukemia? Anybody?
It's Burkitt's lymphoma.
C.
Why? Okay. Why? Can give me reason, please? You can speak one after other. Okay. I will listen to both of you. Yes.
Number first reason is the patient is HIV positive, so lymphoma is very common in these patients. And number two is patient is having retroperitoneal mass and high LDH and starry sky appearance. So that starry sky appearance is very typical for Burkitt's lymphoma. So Burkitt's lymphoma has having two variants. One is African variants and another is sporadic. So the African is commonly involve the head and neck region, most common jaw region, and the sporadic variant is commonly involved the chest and abdominal region.
Good. Good. So anything, Eunice, you want to say here, or any other guys who are listening? Anything?
So in HIV patient, if the CD4 count is less than 100, so maybe there is increased chances of EBV, which will make us Burkitt lymphoma.
Good. There is another point. Agree with your explanation. So all the reasons, okay, are correct here. Absolutely. This is a case of Burkitt lymphoma. Now, the reason he has already told, uh, these are the common symptoms. This is a case of non-Hodgkin's lymphoma, remember? So non-Hodgkin's lymphoma is a type of malignancy, okay, malignancy, and sometimes there are constitutional symptoms present as well, though they are more common in Hodgkin's lymphoma than non-Hodgkin's. But even in non-Hodgkin's lymphoma, the constitutional symptom like sweating and weight loss, fever may occur. And a very important clue is retroperitoneal mass. Non-Hodgkin's lymphoma can present in three different ways. One is head and neck mass, another is mediastinal mass, and third is abdominal mass. Burkitt lymphoma is non-Hodgkin's type of lymphoma. Okay, so this fits in the description. Another one, markedly raised LDS. LDS is intracellular enzyme, and these are lymphoma. So there are numerous cells present in the body. The increased tumor load, we say. So LDS is usually high. If you examine uric acid level also, that will be high. HIV is positive here. Burkitt lymphoma and other types of non-Hodgkin's lymphoma are quite common in the person who are immunocompromised. Remember this clue. Sometimes only this clue is given. So in immunocompromised situation, non-Hodgkin's lymphoma commonly occur. This is one of the example. And the most important clue, if you have ever read Burkitt lymphoma topic, okay, you should always remember this point. Starry sky appearance. This is a typical hallmark of the histological appearance of Burkitt lymphoma. Even if you cannot give any other reason, whenever you see starry sky pattern, this is Burkitt lymphoma. So the answer is very typical here. So this feature suggests Burkitt lymphoma, a highly aggressive and rapidly proliferating mature B-cell tumor, hence the high LDH. It has a strong association with HIV and immunosuppression. Okay, and then the other things are quite easy to explain here. Now, let's move on. Let's go to the number 12. A 65-year-old male has a small left pupil and the eyelid on that side is drooping. Okay, so small left-sided pupil, which is known as meiosis. Small pupil is meiosis, and the eyelid on that side is drooping. What we call that drooping upper eyelid?
Ptosis.
Exactly, ptosis. Okay, this is ptosis. The medical term is ptosis. He was also noted to have wasting of the small muscles of the hand on the left side. So wasting of small muscles of the hand on the left side. So these clues are provided to you, and from this you have to choose the correct answer here. Is it Horner syndrome? Is it third nerve palsy? Is it Addy's pupil? Is it opioid overdose like morphine or pethidine or methadone or heroin, something like that? Or is it R.G. Robertson pupil? So students can take their opportunity here to answer. Yes, this is open question. Yes, you said Horner syndrome, right? Can you explain to me?
Sir, in Horner syndrome, we have like meiosis and ptosis. That's already given in scenario. And there are also some other features like anhydrosis, which is not given. And age is important here. So most probably the patient is having lung cancer, like that Pankot's tumor, which arises from the apex of the lungs, which can cause damage to cervical sympathetic chain and cause Horner syndrome.
Good. The thing which you are saying is so much correct, very, very good. Now, can you explain why there is wasting of the small muscles of the hand on the left side? Why is that?
Sir, because most probably, sir, that mass which arises from the apex also cause damage to the brachial plexus, which innervate those muscles. So that lower motor neuron type of palsy will be there, and wasting is typical feature of that.
Excellent. Okay, very good. So he has fitted everything under Horner syndrome, and he's absolutely correct. Now let me explain, please, the students who are listening here, okay, pay attention. This is a case of Horner syndrome, and Horner syndrome has four features together. Four features. The two of the features are very clearly given here. Is right. Number one is meiosis. Small size pupil is meiosis. Number two, ptosis. Ptosis. Drooping of upper eyelid is called ptosis. Number three, anhydrosis. Okay, it is anhydrosis. That means loss of sweating on the forehead region, anhydrosis. And fourth is called inophthalmos. Inophthalmos means eyeball is shrunken inside. Inophthalmos, okay. Eyeball is shrunken inside because of the atrophy of the pad of fat which is present inside the orbit. So it looks like the eyeball is shrunken inside, and it is usually unilateral presentation. Already told it is on the left side. So these are the four typical features of Horner syndrome. Now the reason for ptosis is Horner syndrome is all about sympathetic nerve involvement. Though the major cause of ptosis is third nerve palsy, but in this case the third nerve is normal. Okay, this is not a disease of third nerve. So how can I explain here now? And the reason is there is a small muscle inside the levator palpebrae superioris, which is supplied by third nerve, and the name of that muscle is Muller's muscle. Okay, Muller's muscle. See here. Okay, wait. This is Muller's muscle. This Muller's muscle is supplied by sympathetic fiber, and because of the paralysis of this muscle, the person has ptosis. But this ptosis is never that alarming type of ptosis, and sometimes if you fail to examine the patient properly, you will easily miss the ptosis also. So ptosis is not a very severe one. Now, what is the cause of Horner syndrome here? Now look at the age of this patient, 65-year-old male, okay, older person, though the history of smoking is not given here, but one of the most common cause of Horner syndrome is bronchozine carcinoma. And he's absolutely correct. It is known as pan-coast tumor because the tumor is usually present towards the apex of the lung, and there is a big mass, and that mass has infiltrated or invaded the local area like a sympathetic ganglia which is present there. Okay, and by doing so it also damages the C8 and T1, okay, part of the brachial plexus, which forms ulnar nerve, and ulnar nerve is responsible for supplying small muscles of the hand. If the ulnar nerve or roots of the ulnar nerves are affected, then the small muscles of the hand are atrophied. Now, can you name what are the names of these small muscles of the hand? Which muscles I'm talking here? Yes,
Lumbricals.
Hypothenar muscles,
good,
lumbricals,
very good.
and thenar muscles,
And one more,
and
interossei. Okay,
yeah, interossei.
interossei. Exactly.
Yes, sir. Interior
Dorsal.
and posterior.
Exactly. They are also known as dorsal interossei and palmar interossei. You're right. Then hypothenar eminence and the two lumbricals. So these are supplied by ulnar nerve. So these are the correct one. Very good. Now another, some other reason I like to highlight here, third nerve palsy. Do not describe everything here. Third nerve palsy results in, ptosis. You're right. But what happens to the pupil if third nerve is paralyzed? What happens to the pupil?
Dilated.
Dilated, sir.
So it doesn't fit, right? It doesn't fit to the description. Here it is given meiosis, but third nerve, lesion will give rise to mydriasis or dilated pupil. Never forget that. Eddy's pupil, this is probably a new term for you, but maybe you have studied in ophthalmology. This Eddy's pupil, okay, when we show the light in the pupil, then it doesn't constrict, it remains bigger in size. There's no constriction at all. Rather, it will become bigger in size, or it remains like that. That is known as Eddie's pupil. And the real reason for Eddie's pupil is idiopathic, but some of the textbook mention it occurs because of damage to the ciliary ganglion. That's why it cannot constrict, because ciliary ganglion is a parasympathetic ganglion. Opioid overdose, morphine and pethidine. What happens to the pupil in opioid overdose? Quick answer. What happens to the pupil?
Pinpoint pupil.
It is called pinpoint pupil. Pinpoint pupil. So both pupils are affected on both sides, and they are pinpointed, and they do not usually react to the light. This is highly typical of opioid poisoning or overdose. And what is the antidote you want to use if this type of patient comes to you? Quick. What is the antidote? Opioid.
Naloxone.
Exactly. Naloxone is the antidote. See this. So related questions, And Argyll-Robertson pupil is seen in which condition? What is the cause of
Syphilis.
this? Syphilis.
Neurosyphilis.
Exactly. This is neurosyphilis. Okay. Argyll-Robertson pupil is seen in neurosyphilis. In this Argyll-Robertson pupil, light reflex is absent, but accommodation reflex is present. This is Argyll-Robertson pupil. So see that. So always, give reasons for each of them, so that if another question is covering those, option, then also you can solve it. So the answer is A here. Okay, we have already explained nicely. Let's move on. Let's talk about another case. A 32-year-old man is known to have complex partial seizure consisting of brief episodes of altered consciousness associated with olfactory hallucinations, episode of deja vu, and a rising epigastric sensation. Which of the following drugs may be helpful in controlling his seizure? Now, first of all, you should diagnose this case, okay, which is very easy for most of the students, I'm sure about it. And after diagnosing, choose the correct options for the treatment. Is it carbamazepine? Is it valproate? Is it propranolol? Or is it amitriptyline? Yes, you can take a bit of time here. What is the answer? So your answer may have more than one options here, okay? Maybe more than one options. Anybody?
A and B.
Yes, sir.
A and B, right? So what is the diagnosis here? Which type of epilepsy is this?
Temporal lobe epilepsy.
Yes, this is temporal lobe epilepsy, which is having all these typical features: complex partial seizure, this see this olfactory hallucination. There is a features of deja vu, which is common there, and there is a features of aura also. This rising epigastric sensation is a feature of aura. So this is temporal lobe epilepsy, and two drugs can be used here: carbamazepine and sodium valproate. Carbamazepine is typically used here, but sodium valproate is a broad spectrum anti-epileptic drug, so it can be used in any of the any type of seizure or any type of epilepsy. So see there, this is how you give explanation here. Okay, A and B. Now let's make this as a last case for today. We have almost come towards the end of today's class. See here, a 35-year-old old woman presents to neurology clinic after developing odd movement of the limbs and face over the last 9 months. Her father had similar problems and died in his 50s. So there is a family history. If father had a similar type of problems, probably it is autosomal dominant disorder now. On examination, she had grimacing of the face and involuntary irregular movement of the arms and leg. What is the most likely diagnosis? Is it Wilson disease? Is it Huntington's disease, Parkinson's disease, Sydenham's chorea, or multiple system atrophy? What is the answer? Just see there, see the options. Okay, look at the clinical problems provided and try to choose the correct one.
Then B, Huntington disease.
Why? Give me reason, please.
Because Huntington disease is a genetic disease, and family history is also important. So her father also having this disease in past. And the most common cause of death in Huntington disease is suicide. And the age of it is more common in female, and age is also near 40s. Near 40s, the Huntington disease started. The symptoms started in that. And the other features are like movement of the limbs and grimacing of the face and irregular movements, which is not controllable, involuntary movement by the patients.
Good. So the most of the points he has mentioned are absolutely correct, and that is the correct answer. This is a Huntington's disease. One of the most important clue here is a autosomal dominant disorder. Okay, it runs in the family, and these are typical chorea. These are called chorea, Huntington's chorea, or choreiform or choric movement, involuntary irregular movement like a dancing type of movements of the arms and leg. Okay, this is typical, and the age, everything is so typical with the important family history. Other things can be ruled out here one after other, one after other. Okay, so at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.